This next section is called Investigating Outbreaks. And what you're going to become after reviewing this section is an infectious disease detective. As you recall, epidemiology grew out of infectious disease. And if you've ever played Clue, the Great Detective Game, or watched Murder, She Wrote, starring Angela Lansbury, the processes are very similar. So we start with clues and information to arrive at the type of disease that we would need to either um, prevent, protect against, or control. So I'd like to talk to you about how we define disease. Now, entire courses are dedicated to this particular topic. So I and many of you have had experience and background in these areas as well. But a disease, as you can see, is we define it as an interruption of life or a cessation or a disorder of bodily functions, systems, or organs. And it arises from an infectious agent. We'll talk about some of the terminology we will use from a public health standpoint to describe how diseases influence humans, or a disease can occur because of some inherent weakness. Um, it would come from a genetic background, lifestyle, or environmental stresses or stressors. So you can probably think of many different circumstances. Let's just take lifestyle because we focus so much on those because those are the ones that are preventable. And we've talked about those earlier. For example, inadequate sleep, poor diet, lack of exercise, etc., etc., or environmental air quality is another one that would have a negative effect on human functioning. We know that factory life or factory work in America is still a very dangerous. It's still a very dangerous environment, and so I ask you really to think about those kind of circumstances as well. We have factories in this area, for example, that produce a lot of noise pollution, and as a result of doing that, people have hearing loss. So I'm trying to give you as many factors to take into account when we talk about disease. And I would, so when we look at wellness, we're also talking about physical disease, and we're talking about mental disease. And we recognize that when people are under stress for long periods or they confront major life events, it often has a very deleterious effect to their bodies and their functioning. In fact, certain parts of the brain are actually eaten away due to prolonged stress. Now, I want you to notice that we're tr- trying to look at the cause, the determinants, or the agents of a disease, and the mechanisms by which they spread remains a primary focus in epidemiology. Because if we can't detect what the disease is, then we have no influence over how it spreads or the determinants or the distribution of the disease, or whether whether we need to take certain actions or not. And you're well aware of etiology, and that has to do with the science and study of the causes of disease and their mode of operation. So As I say, I'm going to give you some rudimentary, and this is about the end of the rudimentary aspects of it, and then go to more of a public health focus. But all of these terms come together when we're talking about the Control of Communicable Diseases Manual. Um, One of the terms that you need to become familiar with is an agent or a disease agent, and you can see it's a factor that promotes a disease. And this can be microorganisms, chemicals, air, water, waste, whatnot. Now, the traditional thought is what we'd always hoped for in the early sciences, that we had one disease agent or determinant that caused a single disease. Um, Oftentimes, what we see is that we have multiple disease agents that lead to a disease. If you take for a minute and you think about obesity, for example, we have probably 30 factors that we look at that are influenced or related to obesity. So we have 30 or 40 disease agents that have an impact on whether or not somebody is obese or not. And this is what makes progress slow in certain scientific areas, and it makes those diseases particularly difficult to treat and affect. Um, of course, we have other types of diseases that we don't do so well with either, that might be viewed as simpler, and I'm not certain that they are by any means, but we might look at the spread of flu, and what are the types of actions, public health actions, that we would take in order to decrease the likelihood of influenza morbidity and mortality. I want to introduce you to some key terms in epidemiology and public health, and I'm taking these terms and I'm looking at them, and they come right from the Control of Communicable Disease Manual. And I want to try and distinguish these terms because these are the terms that you ought to begin to use and you ought to become familiar with. And there's a lot of confusion about these terms, and hopefully I can make this as simple as possible. A reservoir is a natural habitat of the infectious agent. For example, you could think of a pond or a pool of water, and where a mosquito might breed or live. So, and it multiplies, and I think that's probably the best way to look at it. Sometimes we refer to it as a hotel, just the living quarters, and of the disease. It doesn't have anything to do with its spread. It's just where the disease resides. So, and we're interested in its development. How quickly does it multiply? How quickly in a pond would we have more capability of disease? The next term I want to introduce you to is mode of transmission. And how do we get a disease from one individual to another? So, and what we would talk about again is the infectious agent. How is it spread? And of course, it can be airborne, it can be waterborne, it can be vehicle-borne, it can be food-borne, or vector-borne. And I'll go through and I'll define each one of those terms for you. A host is a person or place where, a person, living animal, for example, birds or arthropods, insects that harbors a disease. So we're dealing with where it lives, and you may be the place where a particular disease would live for a while. For example, influenza, pneumonia, um, and it could be acute or chronic. Wouldn't make any difference. Another public health term is the period of communicability, the time that you're contagious or infectious. So, if you have influenza, how long a period is it that you're likely to infect somebody else? When is the time that people should avoid you or you should avoid connection with others? And we're trying to develop and think about policies in this area, and they aren't very widespread yet. We still encourage people to go to work when they're ill, and the fact is that the mode of transmission of the disease would come to play, and the host would contaminate others in a variety of different ways, and I'll talk about how that disease gets spread here in a moment. And last is susceptibility, and you can sort of see this as what kind of shape are you in? How well have you taken care of yourself? And there's a number of things that influence and affect that, and we talk about them routinely. And if you're are you run down? Are you overstressed? Do you smoke? Do you drink alcohol? Do you not engage in physical activity? Um, what are the behaviors that cause you to be more susceptible to the disease? And of course, there's a wide variety of factors that come into play. But if we help individuals focus on this, they ought to have more immunity and therefore be able to ward off disease. Now, I want to talk about two main ways to transmit disease. That's direct and indirect. And if you look at the direct methods, most people think that these are the quote the fun ones, and you can. I'm not going to ask you to comment on it, but maybe this is an easier way to remember them. The most direct transmission of disease is through touching, kissing, biting, coughing, and sexual intercourse. So these are the direct pathogens that get transmitted the most rapidly from one person to another. So you can especially see if you've got the disease, again, going back to influenza, touching, kissing, coughing, sexual intercourse, biting, all those things are more likely to lead to disease. Now I want to switch for a moment and talk about indirect transmission of disease. And there are a number of ways that this happens, and they happen through fomites. And as it says here, that's an inanimate object. And I'd like you to think about fomites just for a minute, because there's all kinds of them in which bacteria and viruses live on some fomites for 24 to 48 hours or longer, some of them even days. So when we think of a fomite, we think of a door handle. We think of a pen or a pencil. We think of a coffee pot or a coffee pot handle. We think of a telephone. We think of the faucets in a bathroom. The toilet paper dispenser in a bathroom. Anything where the public comes in frequent contact with an inanimate object, doors that don't have handles but have metal bars, anything that many people touch is a way to spread disease. We'll talk about contaminated food. You know something about contaminated water and infected insects or vectors, and that's another public health word that you will come to hear and appreciate a lot. So a vector is something that you ought to think about as well. Now, I want to talk about the indirect transmissions of disease, and there are three major categories. They're vehicle-borne, food-borne, and vector-borne. Now, when we talk about vehicle-borne, we're talking about fomites, and these are all inanimate objects that need infection control. They need to be cleaned. They need to be sanitized. And I've mentioned the doorknobs, but you can think about tabletops and desks in the break room, the machine, the candy machine, or any of the dispensing machines. The button on the water cooler is one of the filthiest. Keyboards, that's something that everybody uses, and oftentimes they share. Headsets on phones, cooking surface, and the toilet lid, and approximately to the proximity of your toothbrush to your toilet. One of the things they recommend is that you, every time the toilet flushes, it sprays, and there's a vapor that's left in the room, and if your toothbrush is close to the toilet, you're contaminating your toothbrush, so you'd want to move that further away from it. Foodborne transmission has to do with contaminated foods, and those that are well known are raw or undercooked chicken or eggs, and or anything that's contaminated during the growing process. We've heard about spinach, for example, and it being infected by infected manure. So it's important to take that into account. Now, vector-borne transmission is a pathogen is transmitted via an intermediate organism, and for example, pig and flu, or the swine flu, and mosquitoes and malaria. Now, we also know that 75% of all diseases are transmitted through animals to humans. So we have an area called zoonosis, and people frequently wonder why veterinary medicine is so interested in epidemiology, and that's one of the reasons because of this statistic. The military uses veterinarians to inspect meat to make certain it's non-diseased and it's consumable and proper for consumption. I'd like to talk about the steps involved in investigating an outbreak. Now, we're well aware about the difference between an outbreak, an epidemic, and a pandemic. And the first thing that we need to do anytime that we're in an investigative process and we're trying to determine what the disease is the disease has to be diagnosed. Now, it's not always immediately diagnosed, and I'm going to show you ways that through information that we can come to a conclusion without serology or taking blood or using any other means to know what the disease is. So we have to be always clear of what the criteria are for what constitutes a given disease. So that's the important first step. The important second step is we need to know the endemic state compared to whether there's been a change. So the endemic state, again, we can think of the baseline. And if we have sharp spikes or changes in the occurrence or incidence rate of a behavior, then this is a pretty important clue that we've got a problem that's going on that we may need to do something about. Now, I've mentioned the criteria, especially with waterborne and foodborne diseases. I've already mentioned the criteria for when we're looking at diseases, we're always comparing it to the endemic state, and we want as long a period preceding the disease as possible so we can see whether the spike is really truly significant and does in fact change. Now, when I go back to a foodborne or water disease, the first case or case one is the endemic state, because it would be the steady state. It's not, if we only had one case, we wouldn't count that as being a foodborne or waterborne outbreak. So it takes at least two cases to qualify it. But saying it differently, the expected would be one case, and if the observed was greater than the expected, that would be two cases. So if we observed two cases expecting one, in this case two and greater would indicate some kind of problem. Now, also you should note that we're interested not only in those people who are ill, and we want to interview them and find out as much about them as we can. And I'm going to talk about this later so that you understand that the collection of data from individuals about the various circumstances and consequences that they have encountered are very important to this entire process of deciding on whether we have an important disease worthy of our attention and future steps. Now, we want to define the distribution, and you know that that this has been something important to us all along. And if you go back and you look at the initial definition of epidemiology, the first word in it is a distribution, and we have those whole host of words that have demic in them that help us define that distribution. But primarily what we're always looking at is whether the observed is greater than the expected. We wanted to define the case, and we want to define the population at risk. So if we had an outbreak that was restricted to a small location, we would want to know, we would want to look at two groups, those people that became ill and those people who didn't become ill. But still, the total population would be the denominator. The total number of people present at the event would be the denominator, and those who became ill would be the numerator. Okay, the next step is we want to find a distribution, and as you remember, we talked about the distribution before in the definition of epidemiology. I'm hoping I'm not repeating myself to you because we stopped here for just a second. But there's all kinds of terms that end in the demic that help us to define the distribution. But if we were, let's take a foodborne outbreak, and that's what just to as one means to focus our attention. If we had a church picnic and we had 100 people that attended, the population at risk would be that those 100 people. The numerator would be those people that became ill by eating a particular food. So we would want to be very um, sure about caseness, or what is the case, or what are the criteria for somebody being for us to consider that somebody has a foodborne illness. Now, person, place, and time is always important in any of our analyses of a problem. We're going back to descriptive epidemiology again, and we want to consider difference in variables. For example, we could look at chocolate or vanilla ice cream associated with the illness, or we could look at any number of other foods and factors. And I'm going to show you forms used by our public health agencies locally and statewide and nationally to investigate a foodborne outbreak. I'm sorry I didn't keep up with you there, but I'm certain you've been following along and you've been keeping up with me. So if I get behind, just do that. Okay. And the next thing we were really wanting to do is we want to develop a hypothesis. And when we start developing hypotheses, we're going into analytic epidemiology, and we're asking, what is a determinant? What is the agent? What's a vector, or the food that seems to be associated with the foodborne illness? And so we might be investigating not only those people who came, but those people who left the foodborne event. So we might be consulting physicians, hospitals, and others to find out our denominator, or the number of people at risk. So that's very important to us, or to help us with the numerator to know how many became ill. So we're always interested in these two factors, the agent, and always looking at the total number of people who have become ill, who have been associated or affiliated with the foodborne outbreak. Otherwise, we can't be precise, and we don't know the size or magnitude of the problem. Now, we ultimately want to recommend prevention, protection, and control measures. And when we, for example, if we have a foodborne outbreak, what caused it? We have food safety as a part of public health. One of the things we know that if you go to a delicatessen, they use a meat slicer, and inside that meat slicer, after you clean it, is a little pocket, and sometimes that little pocket is not cleaned well, and it will cause bacteria. So we very much want to know what the etiology or the origin of that particular disease is. And once we have the opportunity, we can begin to review several of the symptoms, or the incubation period, the period of communicability and susceptibility in our manual, and we can look under specific foodborne diseases to see which one might explain the symptoms and the illness itself, along with its duration, and what treatments would be appropriate. This particular manual outlines all kinds of measures and steps to take, so a person is not left to their own devices. All the work has been done for them. Now we have to report the investigation, and We have specific forms for this. This is not a new topic or a new area of concern in terms of public health. So um, we want to review the factors leading to the type of distribution. Okay, are we dealing with an outbreak? Has it gotten more serious than an outbreak? And is it beginning to spread? We want to evaluate whether our intervention methods have worked. Have they been effective? And we also want to recommend the appropriate intervention methods that should be used uh, to keep this problem from happening in the future or to prevent its its reoccurrence. And again, I recommend Heyman in this control of communicable disease manual. It's interesting that this manual was first published in 1915, and there are even downloaded versions by phone now, and many of our epidemiology, public health people have those downloads so they can consult the manual rather quickly and search it. So I highly recommend if you're going to have contact with the patient population or you're going to be involved in any way in any of these kinds of outbreaks that you become familiar and buy this book. I think it's well worth it. And you can usually get copies that do not cost much because you can get them online. You can get used ones. Okay, preventing future outbreaks. Now, when you look at public health, it's got four major arms, and this is always arguable, but um, we talk about reaching the public through health education, and I'm going to start from the bottom and go up, and that's working didactically, teaching people like what I'm doing with you, and they could be on an individual basis or a group basis. We have health promotion, and this is a broader means of this is a population-based approach, and we work with flyers and brochures and radios and television and all kinds of media that are designed to reach a large number of people. There's a book called The Pink Book, and you can Google it under Pink Book. And here's its address, and it tells you how to design public health interventions that are population based from a communication perspective. Another area of focus has to do with policies. And policies are important and usually are not law, but are very important to the health of the individuals that we come in contact with. Perhaps you've been to a restaurant where a person serves food, wears a little apron with money, and makes change with that money. Um, and doesn't involve a register, a cash register, or anything else. Of course, those procedures I haven't seen recently, but they were very much in practice at one time. So 80% of our money has drugs that are in the fibers of the money or in the paper, and you never know where money has been. So you see signs in restaurants about food handlers washing their hands, and they're not to engage in of handling of money and food either. But I'm not certain that plastic credit cards may not carry germs too that could be contagious and cause a foodborne outbreak. Now, we also propose laws, and I'm going to talk to you about holding temperatures of certain foods. And you can laugh about this, but you might think about the next time you go someplace, especially to a smorgasbord, about taking a food thermometer to see whether a food is being held at the right temperature, either hot or cold. Um, Now, another means, and I don't want to overlook this, is that we are using technology. Technology is exploding, and we're combining it in multiple ways, and we're also combining it and using it in public health interventions. Um, one project I'm aware of that's operating in Texas is um, they use text messaging to remind people to engage in certain behaviors. And of course, you see Facebook and blogs, etc. We now even have software that we use to analyze this information. In fact, we use this software um, not too long ago in the last flu um, pandemic, and it was more effective in predicting when the flu would occur in a given area than standard survey means. So surveys will be used probably in some instances, but I suspect there will be a decline in their use because when we deal with electronic social media, we're getting real time data. We're getting data that occurs immediately, and we're able to process it and analyze it and get a lot more information from it than by other means. Now, I want to talk about a foodborne outbreak. Um, um, the primary causes is of contamination is improper holding temperatures, poor employee hygiene, for example, going to the restroom, especially if there's bodily functions involved in. We have noted that in restaurants in Bloomington and other places that if fecal matter comes in contact with food, oftentimes that can cause a foodborne outbreak. Inadequate cooking, contaminated equipment, and food from unsafe sources, and I'm just giving you examples here. Fish from waters with high mercury concentrations, like from Lake Michigan and in Indiana waterways. If you go to some parts of the world living right on near a waterway or an ocean or a river or a lake is a wonderful opportunity. We here in Indiana sort of watch those because of the contamination effects. Now, I also wanted to let you know it's that in some states, for example, that in California they will have a triangle in the window, and if after a food inspection has been conducted with a certain restaurant, and a green triangle means that there's none to minor health infractions after the inspection, and a yellow means that there's more serious health infractions that can be remedied quickly without too much effort. And red means it's serious, and often what they do is they will close a restaurant in those instances. We don't have anything like that I'm aware of in the state of Indiana. We do publish in the paper on Sundays those local food establishments, if they've been inspected, that don't comply with proper regulations. So that's an important element and aspects. And we talked about slicing of meat and whatnot, and being careful about that, and hopefully the equipment has been cleaned and sanitized properly, etc. And that's what a health inspector will do in looking at food safety. Now, this is a foodborne outbreak form, and you can see this is a form used by the state of Indiana. And not that I expect you to memorize and know everything on this form, but this this lets you know that this is an important form, and that foodborne outbreaks are taken seriously. Um, and it is much like the form you're going to see next from the CDC that identifies the food responsible for the outbreak. So the point is that I'm teaching you procedures that are used routinely. I'm teaching you vocabulary that is central to public health and communicating with public health officials. And I'm teaching you ways to investigate a foodborne outbreak in a systematic way, so that you arrive at the right conclusion, so we protect others that do not have the disease or the problem currently, and we offer proper treatment to those who do. Now, you'll notice in reviewing this form that they ask for a lot of demographic information, name and age and occupation and race and all the things we would think of. And then they look at symptoms. And you can see the list of symptoms that they have there. They look at sources of positive specimens. Not always do they get the opportunity to get specimens, but if they do, they want to look at them, and they usually utilize a form like this for people who they know to have the particular disease. Now, notice we're still talking about salmonella, and they're wanting to know, and I think this is particularly interesting because it's happening in our society routinely, or quite frequently, I should say, where people are dying from diseases that can't be treated or cured by antibiotics. MRSA would be one of them. SARS was one in, I think, 2005, where we weren't able to successfully save people's lives. They're wanting to know where all the specimens came from, and what physician is involved, and what commercial eating establishments did the person eat at in the last 5 days, because it's very important, because these are litigious matters. Often they will lead to lawsuits as to which restaurant's being blamed for a particular illness, and you can see why, because if a restaurant gets accused of supplying contaminated food, oftentimes the number of patrons declines quite rapidly. And now, what lists all group gatherings where food was served. So, did they go to a particular gathering like a wedding or a funeral, or any number of other social events where a large number of people were present? Did they go to somebody's home? And what stores are they buying groceries from? Because we're looking from the old statement, or the new one is from farm to fork. So we're trying to look at every intermediary step in between, so we know the thread of contamination and where its origin is, because we've got to stop it at the source. And you can see the foods and that are listed here, and there are plenty of them, and they're looking, you can probably tell pretty quickly that they have to do with meats and eggs and things made with eggs. So they want to examine that carefully. Um, so, and of course, coming right up on the next page has to do with undercooked or meat or eggs. As I mentioned, the ones that precede it, the foods that precede it on the checklist fall under these two main categories. Other things that might influence whether or not you'd have a foodborne outbreak would be, or some kind of disease transmission that would cause illness, would be wild birds and reptiles and farm animals and poultry and pets and whatnot, because all of these transmit disease. We don't think of it very often, but they do, and you just learned that 75% of the diseases that influence man are transmitted to him by animals. And of course, when we talk about wild birds, um, we talk about them being in contact with insects such as mosquitoes, and it's quite a vicious cycle to understand how we can stop that occurrence of disease transmission from happening. Okay, I think I've covered this pretty thoroughly in terms of the Indiana form, and of course you can make comments and the investigator's name and whatnot. Now, here's the national outbreak form from the CDC. What you'll find, and I'm not going to go over this one as carefully because I wanted you to see the Indiana form and become familiar with it. But you can see that the CDC form is a little more thorough because the intention is it can be used almost any place, and there is concerned about the tracking process as Indiana in terms of identifying where the origin of the problem occurs so they know what to do, whether they need to pull things off the shelf or just what is required in order to offer some control. So you can just sort of go through it, and incubation period is an important word that we're going to spend time with, and it comes from the Control of Communicable Diseases manual. And I'll talk more about it, and we'll look at duration of the disease as well, and we have signs and symptoms, and we'll discriminate primary from secondary cases, and so the process here is just, it's very similar but just more detailed, and when you have a chance you can go through it and look at it very carefully and see what the differences are. I think you'll enjoy the process, and I think you'll see that we're pretty active in this area about people not becoming sick by contaminated food or diseases being transmitted by other means. Okay, now, in other important terms that we want to identify in tracking a disease or investigating a disease has to do with the index case, and this is the very first person that has a disease. And why would we want to identify that person? Why would we want to go back and investigate and look at and identify the person who first has the disease? Why is that so important? The first thing we would do under this circumstances, we would interview this person. We would find out what they've been in contact with, what they've done, what foods they'd consumed, what symptoms they've had, how long has it gone on, or the duration of it. We would ask about, in other words, we would try to look at the reservoir, the and all the other terms that we'd looked at before. We would be investigating to see whether or not this person could help us with the origin of the disease. Now, Another term that is important for you to know is the primary case. Now, the primary case is not an index case. An index case is the first person who has the disease, but this group is usually so closely internet or close to the index case that that it's hard to differentiate. Um, but these are the individuals who introduce the disease into a family or group under study, and not necessarily the first diagnosed case in a family or group, as I'd mentioned. So, and we may have co-primaries. So we may have not a primary case, we do have an index case, but we have primary cases. And so we often call these co-primary cases. Now, secondary cases, um, these are the people who got the disease from the index case or the co-primary cases. And I want to show you a diagram to help make this clearer as to what I'm trying to point out between the three different types. But we're trying, again, this is part of the investigative process, and we're trying to obtain information from each of these groups that's going to lead us to what the cause of the disease is, and how widespread it is, how many resources it's going to take, and what we're going to need to do to prevent, control, or protect people. So if we look at this together, you'll see that we're going to look at, we're thinking about the primary attack rate. Well, somebody asks you what the primary attack rate is, it's 100%. And that the reason it's 100% is because that index case is the one who gets the disease. There's one index case, so that makes 100%. So now the percentages are different with the secondary attack rate, and we're going to talk about this, and I'm going to show you how to calculate it and what we're going to do with that information. So this is what I was trying to talk about earlier, suggest that that co-primary cases really belong to the same generation of cases as the index case. But a secondary attack rate describes the spread of disease within a group, excluding the index cases and co-primary cases. So when you think of an index case and a co-primary or co-primary cases, they're so close in time that sometimes it's real difficult to separate those out. That's the point here. Now, let me show you in this example. We're going to use this example again. But if we talk about, here's an index case, and you can see the index case very clearly, and you can see the co-primary cases, and this is time across the bottom. You can see that closely following the index case are the co-primary cases. And the co-primary cases spread it to family or to other individuals. So you can see that with this top primary case, or actually a co-primary case, that this person is spreading it to 1, 2, and 3 people. Now, the dark circle means that the disease is not spread. And what occurs here is that this person has immunity to the disease, so it doesn't go any further. It doesn't go on to another individual. Now you can see in the case of the secondary, the second co-primary case, that the disease is spread to one person, it's spread to another person, immunity occurs and it stops here. But then all of this continues for a long time. So this one co-primary case influences many secondary cases. Now we can see with this, the third one, that it influences one individual and then immunity occurs. And then with this next one, the same one, it influences several different people, and you can see where immunity occurs. So when we look at this, we talk about index cases, co-primary cases, and from this black line forward, these are secondary and tertiary cases that occurred because of contact with the index case or the co-primary cases, and that could be from indirect or direct means of transmission. Okay, so as we go on to the next slide, let's do a critical analysis here to see how we would come up with the secondary attack rates of mumps. Now notice under this particular case it's broken down by age, and you've seen this kind of breakdown before in age categories. And again, this could be broken down by any demographic variable. It doesn't have to be by age. But let's see what we're going to do in terms of how we're going to calculate the secondary attack rate. Notice what the formula is for the secondary attack rate. Number of secondary and tertiary cases divided by the number of susceptible cases minus the number of primary and co-primary cases. So we're not going to have the primary and co-primary cases there, and we're going to multiply by 100%. Now let me take you through this so you understand it. So we have 12 people who are secondary and tertiary cases in this example, and so we take that's the people that we're interested in. The susceptibles in this particular case is 54. So this should be a division sign, and it is down here. So we have 12 divided by 54. Now, in this next example, we don't take into account the primary and co-primary cases. So 69 from, we just don't take that factor into account at all, but we do take into account the secondary cases. And then we want to remove the primary and co-primary cases, so we subtract 69 from 168 to give us 99. And again, we take into account the secondary and tertiary cases, and then we subtract the primary and co-primary cases from the susceptibles. And let's see, we have 82, and we continue this process right on down as we complete the table. The percentages then is 12 divided by 54 times 100 gives us 22%. So as we look at this, I would ask you to carefully do some analysis as we have focused on the formula. And the question becomes is what age or age groups would be your priority and why? Well, how are we going to ascertain that? What we would do is we'd look at these percentages. And if we're looking at where we would spend our time, we'd probably spend our time with those who are from 2 to 9, right? If you're combining 68 and 54%, these are the two highest groups, so those would be deserving of your time. If you treated the total number of cases, it would be a very inefficient way to proceed, and it would not be cost effective. So This is why we're focusing on the secondary cases. We've already identified the primaries and the co-primaries, so they're going to get treatment. I mean, those people have been selected for treatment, and then we want to look at the secondary cases because we know not every one of the secondary cases is going to get the disease as we saw before. Okay, let me move forward here. Okay, I'd like to introduce you to a church supper, and this is a famous one, and I would be remiss in not talking about this particular incident. And yeah, people say, well, it happened a long time ago. That's true. The situation I'm going to show you is a factual one, and it's one we teach in epidemiology all the time because it was one of the very first, and so we use the same principles today that we used back then. And obviously, the reason why we have done this is because foodborne outbreaks are common. So anyway, I'm just going to read this to you so you can follow along. It says on April 19th, 1940, the local health officer in the village of Lycoming, Oswego County, New York, reported an outbreak of acute gastrointestinal illness to an epidemiologist in training who was assigned to conduct an investigation. Now, I want to also relay to you that this same process was used in a foodborne outbreak in Bloomington, Indiana, where IU is. Same exact procedures. And it was done with a particular corporation I don't want to mention, but they brought in 3 epidemiologists, 3 lawyers, the CEO, and one of his underlings. And to refute my buddy who had done the investigation in just the way I'm showing you and we'll be talking about. When Dr. Rubin arrived on site, he learned from the health officer that all the patients had attended a church supper held on the previous evening, April 18th. Family members who did not attend the church supper did not become ill. Now that's an important fact. If they'd gotten ill at home, as well as the people that had gotten ill by attending the church banquet, we couldn't restrict the occurrence of the disease or the outbreak to the church supper. It would involve more than that. Accordingly, the investigation was centered about the circumstances surrounding the church supper, and you can understand why. Next up, interviews regarding the occurrence of symptoms, the data and hour of onset, and the food served at the church supper were completed on 75 out of 80 persons known to have been present. So this is remarkable that they had that many people that were still available on which they could collect this data. Normally you don't have that high of response rate. And a total of those 75 people that they could collect data for had GI illness, or they had gastrointestinal illness. Now I want to show you that I want to talk to you a bit more that the supper was held in the basement of the village church, and many of you have attended similar things, and many members of the congregation contributed food dishes, so you could call it a potluck or a pitch-in or whatnot. The supper was held from 6 p.m. to 11 p.m., and That's a long time, by the way. That's 5 hours that this supper was going on. And food was placed on a table and consumed by visitors over a period of several hours. So um, that 5 hour period, again, is a long period to have food out and available. Now, what are the facts? Well, here's one of them. The illness was an acute gastrointestinal illness. The people who did not attend the supper did not get sick, whereas many of the people who attended the supper did get sick. We got 46 of them that got sick. So when you look at it, 46 of 75, we're talking about nearly 2/3 of all the people who attended were interviewed and that got sick. That's a high percentage of people that got sick. And remember, it's a high incidence. It's not a rate because we're not doing any particular math. We have it in a percentage form. But an incidence of 46 cases far exceeds the 2 cases required by the CDC for a foodborne outbreak. So definitely when we look at the endemic state, it's greater than 1, and when you look at 46, it's far greater than 2. So that's how you would interpret that information thus far. Okay, what are the facts? Various attendees contributed food. And this always increases the possible sources of contamination. For example, soiled hands, unclean cooked surfaces, improper holding temperatures, or purchasing food from a contaminated source. And another thing that you would want to be aware of and should be aware of these are the holding temperatures. We want food held, especially in a smorgasbord or where food is going to be left out. It should be hotter than 140 degrees Fahrenheit or 60 degrees Celsius. If it's cold, it should be below 40 degrees Fahrenheit. And so those two temperatures are ones that you want to keep in mind. So if you're looking at a cooler, a large cooler or a refrigerator, you want to make certain that it's 40 degrees or lower. I was in a situation where the food was not, it reached 45 to 50 degrees, and we had to clear the refrigerator. It was a big refrigerator. It was a big dining facility, and all that food had to be thrown away because it was contaminated. And and if you're going to freeze it, you want it below 0 degrees or 0 or below for Fahrenheit. Now, I know you all don't have thermometers and our food thermometers, and you don't carry them around with you. I jokingly have said to other classes that I've taught that maybe it would be very wise to put one in your purse or carry it on your person in some place and slip it into the food container to see how hot the food is being retained at in terms of temperature. And usually what you'll find is it's not 140 degrees. And the reason if it's 140 degrees is the food tends to dry out rapidly. And so they can't use it as long. And it doesn't taste as good, so they have to throw it away. And if you're looking at products that are supposed to be kept cold, oftentimes they're put on ice and the ice melts and that ice isn't replenished, and so the proper holding temperature for cold has been exceeded. So those are two very critical, important factors that you ought to know about, and especially if you're responsible for a a church supper, or you're attending a large gathering where food is being served, or you're hiring a caterer for a given event, you would want to know about holding temperatures, and you would want to make certain that they knew about holding temperature as well. One thing I did want to mention, that I mentioned that there were 75 out of 80 people that we could still contact. So the response rate in our case was 93.75%, which is remarkable, because again, if people would have left, then we would have needed to track them down to begin to ask them a series of questions that you will see that I'm going to be asking you about here in just a minute. Okay, these are 4 key terms that you need to know. These are 4 key terms that you need to know, because they're going to help you in determining who's sick and who's not sick, and who ate the food and who didn't eat the food. And let me just go through these with you. And if you once memorize them, they're pretty easy, and you can see how charts are developed based on them. Ill and ate it means ill and ate that particular food. Not ill and ate it. Ill and did not eat it. Not ill and did not eat it. Okay, so in epidemiology, we often work by 2x2 contingency tables, and you can see that this covers every possibility. So I'll show you how we're going to use this information as we review the upcoming slides. Now, this is what we call an unorganized or a random listing of cases. Now, if you look at this very carefully, you'll notice the case numbers are all in the right order. Okay, so they're consecutive, and I want to go on to the next one, then I'll come back. And it goes down to 75, just as we talked about initially, as the number of people who were present. Okay, the next 2 things that they gathered was information about age and sex, and the time of the meal, when they sat down to eat the meal. Okay, so the time of the meal, and then whether they became ill or not, and the date of onset, what time did they eat it, and the time of onset of the symptoms. Okay, and the ends have to do with no, they didn't eat it, and yes, they did. So you got an N and a Y. So N for no and Y for yes. And you can tell these are all the foods that were there that they thought were important to keep track of. Okay? So now it's random. The reason why it's random, the list is perceived as random, because they aren't organized or sorted according to whether they are ill or not. Okay, because those were the key things that we wanted to ill and ate it, and so on. So to organize it, we were going to sort it into 2 groups. Those that became ill, that would be the yeses, and those that didn't become ill. Okay, so let's look at the next one. And it's the same way. It's random, it's mixed up, and it's not organized in a fashion that's correct. Okay, same information. All right. Now I'd like to take you to I want to address the incubation period. And this is, after a person sits down for a meal, when we're talking about incubation period, and this is a very important term, again, it's covered in the Control of Communicable Disease Manual. So if a person eats a particular food that's contaminated, how long is it before he or she becomes ill? This is important information that will help us identify the food that is responsible for the illness. Okay? And I want you to know that latency is synonymous with incubation, and we want to know how the incubation period and the clinical symptoms help to determine the diagnosis of a disease. And I'm going to show you. Okay, now this is just information that I thought that you would like to know. We're always wanting to know, okay, I have symptoms. Now, when is it that I'm going to display illness? So, with the common cold, it's 12 to 72 hours. Strep throat, you can go right on down and you can see how long it's going to be. And we have them, the point of the chart is some of them are in hours, some of them are in days, some of them are in weeks, and some of them are in years. So, just something for you to take into account. Now, these are pathogens for foodborne diseases, and staphylococcal. Uh, we're looking at the pathogen, and we're looking at the incubation period, and it's 30 minutes to 8 hours, or usually 2 to 4 hours. And you can go down and read the time period for each one, but those time periods are going to be critical to us in incubation period, because we're going to compute or figure the incubation period from the data that I just showed you. Okay, so and you'll be able to see which one best fits our data. Now, these are the 5 deadliest foodborne illnesses. Now, some of these you know about, some of them you don't, but I encourage you again to go through the Control of Communicable Diseases manual. We purposely left it this way so that you might take more of an interest in learning more about these, and seeing what they are and when they occur, and their incubation period and their duration, and the proper methods to treat them. So, in each one of these will be listed in the Control of Communicable Diseases manual. Okay, now this is a disease course. Okay, we've talked about susceptibility, and we talked about those occasions that make you more susceptible to illness. And we know about the incubation period. So at the beginning of it, I don't feel good. How long is it before I show signs and symptoms? Okay, so and it's also called the latent period. And then, so we got exposure, we got a pathological process and change within the body that's occurring here. We've got the onset of symptoms, and we got the clinical phase of being sick and feeling lousy and maybe being bedridden, and then the onset of recovery. Now, I want to point out real carefully here, that it doesn't go through each of these. Not every disease is going to result in disability or death, and hopefully the outcome is recovery. Okay, next what I want to do is I want to show you an organized line listing of those ill and those not. And if you take just a minute, you can see that we're organized. We've taken the cases that were all ill, right? And you can see, and this is how we organize them. Every one of them is a yes, and I'll explain the other values here in a minute. And then on the next one, and it's very important to know which of these that you're using to come up with a total number of cases that you're going to be counting to go into a chart soon. Okay? So how we have organized the second page is these are people that, all of these people are not ill. So if you go back, we have ill and we have not ill. And then we're going to have ill and ate it, ill and didn't eat it. And then on this page, we're going to have not ill and ate it, and um, not ill and didn't eat it. And those are those four statements that I was talking to you about earlier that you've got to know, and you got to know which page you're counting data on. Now, with this particular example, you can count the wrong information. You can be on the first page and counting yeses and nos and come up with the same answer as you were if you were using both pages. So I warn you that it can be tricky if you don't count the information on the correct page. All right, let's go on to the next slide. Okay, now remember, these are the four statements that I thought were important for you to know, and I've already talked about a little bit. Ill and ate it, not ill and ate it, ill and did not eat it, and not ill and did not eat it. Okay, so you have two for each. You have ill, and that's the Y page, and you have not ill, that's the no page. So yes page, right? 1 and 3, no page 2 and 4. As we were talking about, I had indicated that there are four key phrases that you need to know cold and know how to utilize for a foodborne outbreak. And I want to show you how to use these phrases, and we're going to also use the organized line listings that I had introduced to you before. And the problem with the line listings, I don't know that it's a problem, but if you count the wrong way, you may get the correct answer for part of the exercise, but you won't get it for all of it. And I would like to make this a homework assignment and give you a chance to practice your skills, because this will be included on the test. So if you know how to do it, you shouldn't have any difficulties. And I'll try and be succinct and hopefully as clear as possible, so you can go through it very quickly and with confidence. So we want to know, we have in two organized line listings. One, the first line listing contains everybody that got sick, and if you remember, that line listing looked like this. And then on the second organized line listing that's no longer random, of course, the way we made certain it wasn't random as we organized those who were sick and those who were not sick. Now, I'm going to show you a table because I'm going to jump ahead to what it is that we're trying to accomplish so you understand and you've got an overview. I want to let you know that there's a car, and these are the parts of the car, and we're going to be fitting information into this particular vehicle. So, but first off, the recognition of what you're trying to do and accomplish, I think, will help you understand much better. Okay, what we're going to do, and this is original data from this church supper at Oswego County, New York. So you're seeing it just like the epidemiologist back then saw it, Dr. Rubin. And but again, it's important to know what to count and on which of the two pages you're going to count. Okay, so if you look at, it says Group A, persons who ate specified food and became ill. So this is what? Ill and ate it, right? That's what we're looking at. And so as we go through this, we want to keep these phrases in mind. So now what we're going to do then is we're going to go back, and I'm going to go back with you, and we're going to count those people who ate baked ham and became, we're going to look at those people who are ill and then 8 baked ham. So if we go through here, we would count all the Y's, and let's see whether we can do that together. And it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29. Now I want to take you quickly to the chart again, and you see in this category, baked ham, these are people who ate the specified food and became ill. Now the question is where do we get to 17? Now in this example, I'm going to go back to the graphics here. Some people would say, well, I'm just going to count it under this category. I'll just count not ill here. Well, you could count them and you will get the right answer. But this is a group that's ill. So if I counted if I use this form, which I shouldn't be using, and I counted, I would come up with 17. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Well, boy, I would really celebrate. Now let's go back and see what it says. Oh, it says 17. Well, that isn't where you count them. You're going to switch between the ill and the not ill. So we want persons who ate the specified food but did not become ill. So therefore we go to the second page. Not ill and ate the specified food. So we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So we use the first form, which showed us the ill people and who ate the food, and then we used the second form and looked at the not ill people but yet ate the food. Okay, so let's go back to our graphic, and you see that we have 17. And so what we're going to do is we're going to take the 29 plus the 17, which comes up to 46, and we're going to divide 29 by 46 to come up with our attack rate of 63.0. Okay, are you with me so far? I hope you are. Now what I want to do is I want to go over to the second group, Group B. Persons who did not eat specified food and were ill. So when you see that ill, you know immediately that you're going to the ill organized line listing. So let's do that. And we already know what the answer is, but let's do it anyway. So we would come, here's the ill. It says right there, ill and did not eat it. So we look at all the ill people, and then we would count the no's for baked ham. And we've already gone through that, and we counted up. There was 17. All right. So let's go back and look at the chart, and we see that there are 17. Now it says persons who did not eat specified food and were not ill. So we're going to go to the second page of the organized line listing, and we're going to look at those who were not ill. So we're on the not ill sheet. Okay, let's go back and look. Not ill. And so they were not ill and they didn't eat it, right? So we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And that's the correct answer. And let's go back and look at it again. And we see that we have 12. So 17 plus 12 is 29. Divide 17 by 29 and you come up with an attack rate of 58.6. Now let's do one more because I want you to do the rest of them, and you've got all the answers here so you can develop some confidence in using these phrases and working between the two sheets. And I know you're capable of doing that. And if you have questions, let me know and we'll get them answered. Okay, so we're going to go to Group A, persons who ate specified food. Now, would I expect you to set up a table? Probably not. Probably I'll set the table up for you to get you started on the test, but you'll be able to, it's going to be open book and you can come back and look at this chart and see how to do it if you can't remember. Okay? So let's go to spinach. That's the second food. And we're going to go to those people who were ill. And here's the spinach column. And so they ate it. First they were ill and they ate it. So let's count together. We got how many Y's? We got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, and I'm going to come down here to 24, 25, 26. Let's see whether I counted correctly. Okay. We'll go down and look again, and sure enough, there were 26. So I got this from the ill page, and they ate it, and 26 of them became ill. Okay. Now the next one I want to see is I want to go to the not ill page, and I want to see how many ate it, right? So I'm going to go to the second sheet. Let's go there. And here we will see we're going to look at spinach, not ill, and they ate it. So how many do we have here? We got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. Let's see whether I did okay in coming up with the right answer. By golly, I did. So we would add the 26 plus 17 to come up with 43, and the attack rate is 60.5. Okay, now we go to Group B, persons who did not eat specified food and became ill. So we're going to go to the ill page, right? Let's go do that. Persons who did not eat the specified food and became ill. Okay, so here we got ill and they didn't eat it. So we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Let's see how well I did in my counting. Okay, and sure enough, there are 20 of them. Now, I want to go to Group B again, persons who did not eat the specified food and were not ill. So we're going to go to the second page and we're going to look at the not ills, right? And here they are. So they're not ill and they didn't eat it. So we go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Let's see whether I counted correctly, and sure enough I did. And so we got 20 plus 12 equals 32, and we're going to divide the 20 by the 32 to come up with a percentage or an attack rate of 62.5. All right. So you would continue this process for all these other food or drink items listed on the organized line listings. Now, I want to go back and talk about something that this one's missing. Okay, this is a missing observation. So you can't count it one way or the other. It's a question mark, and so you can't count it as either a yes or a no, so you just overlook it, is what you do. And so don't worry about that, and just remember that if you don't know whether they became ill and ate it, or they didn't, or they ate it and didn't become ill, you can't make a determination because it's a question mark. Okay, now another thing I want to share with you is you want to look at the differences between these percentages. So you look at 63 versus 58.6, and you'll come up with plus 4.4. And for the second one, we looked at it was 60.5 and 62.5 in it. We're going to record that as a minus because this is the target group, because this is the ill group. And so this is where our focus is, and that's what determines the sign. Now you can see as we go, there's attack rates for each one of these. And as you eyeball the attack rates, you can see that the problem, wow, look at the difference. 79.6 for those people who ate it versus the others. And you see that the 79.6, you're going to subtract it from 14.3, and 65.3% who ate vanilla ice cream became ill. So this is our target food. This is the culprit. This is the food that has caused people to become ill in this particular instance. Remember, this is a pitch-in or a potluck, so now we've got an identified food that we can focus on. Now, but there's a few things that we need to do with our line listings, and I want to go back to those and show you how to do that. Okay, what we want to do is we're after the incubation period. So that's when they had no symptoms to the time that they had symptoms. Okay, so when we look at this, the person started the meal at 11 a.m. Interesting, it took them 4 hours to consume it, but independent of that, this is the actual data. So there's the 4. So 11 a.m. to 3 p.m. is 4 hours. Okay, so I'm demonstrating that in hours. Now, some of these people didn't know when they began the meal, so we have a group of unknowns. They know when the time of onset of symptoms were, but we can't use their data, and I'll tell you how valuable and important their data is, because this incubation period will help us to determine the disease in this particular case. Okay, now we look at the next person. Let me get squared away here. 7:30 versus 10:30, so there's 3 hours, and 7:30 versus 10:30, there's another 3 hours, and you can go right down this list and come up. You can see how I calculated the incubation period, no symptoms to symptoms, for each one of these particular people. Okay, now I've happened to count these, and you can too. We have an N of 22. There are 22 people that we have data for the incubation period for. Okay? Now, the incubation period is only covered or addressed on the ill form, and that makes sense because otherwise there wouldn't. Otherwise, those who weren't ill would be listed on this page because they would have no symptoms, and then they would move to symptoms. I hope that makes sense to you, and I hope I've said that clearly. Okay, so you can see that we have a minimum value of 3, and I think down here a maximum value of 7 in terms of the incubation period. Okay, now let's move on a bit. I'm hoping you're understanding all of this and you'll be able to complete this table. Now what I did here, because what we're interested in epidemiology more often than not is a median value, not the average or the mean, but the median value. And what happens is usually we have a lot of variability, and that's why we use a median value. Or there's a great spread between, well, we had 3 hours and 7 hours, and that's depicted here. And so there's a lot of variation between no symptoms and when people displayed symptoms. Now, we're going to look, we're going to identify the median. And the median is the middle case. And if you think about a median, we have a median in a highway that separates the lanes. That's that middle area. Okay? And translated to this, we are looking at the middle score to determine what the median is. Now, don't get confused and just listen to me very carefully, because people have a lot of trouble with this for some reason. I now need to go back to my graphic in the ill listing, and I need to count how many 3s. I laid this out based on the data. Okay, let's go back and look. And we're going to see how many 3s there are. And there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 3s. So that indicates that 10 of these people, the incubation period, no symptoms to symptoms, was 3 hours. Okay? And so let's go down and look and see whether I've done this correctly. By golly, I have. We have 10, and the bar goes to 10 cases. So let's look at the 4s next. We don't have any 3.5s, and we don't have any 5s, and we don't have any 7.5s. But let's go look at the 4s for just a second, okay? You stick with me here, and let's count the 4s. 1, 2, 3. There's 4 of them. Now let's see whether I have graphed this correctly or not. And I hope that I have. And sure enough, it shows that we have 4 4s. And then we looked at the 4.5s, and we went back to the ill line listing and counted those. And then we had 1 5.5, and we had 2 6s and 2 6.5s and 1 7. Now, to come up with a median, we're looking for the middle score. We have 22 cases, so let's count together to find out where the median lies. Okay, so we're going to where the middle case lies. Okay, so we go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Because right in the middle, the middle case is 11. So the median happens to be, in this case, 4 hours between no symptoms and symptoms. So 11 is not the answer. 4 hours is the answer, because we're trying to look for the median in terms of the number of hours. This is a very valuable and important figure because it has to do with the incubation period, which is reported for every foodborne disease in the Control of Communicable Diseases Manual. So you and I don't have a clue as to what disease it is. We have a excellent idea about the determinant or the agent in this particular case, and that is vanilla ice cream. Okay, so let's continue with the exercise. There it shows the median incubation period is 4 hours, and you know how I got it, and you can think about it further, and you can consult any beginning statistics book and learn how to calculate the median, and there's other ways to calculate it, but I'm not going to spend time on that at this level. Okay, so determine, here's another example, food intoxication at a military base in Texas. This is Fort Bliss, I'm almost positive. And we're trying to determine, this is another opportunity to determine the incubation period. So how we would do this one is, this is done just a little differently. And I want to mention that this is a common source epidemic. Now, the other one was a common source epidemic too, the Oswego, New York 1940 study was a common source epidemic because they all ate vanilla ice cream, which was the common source of infection. Okay, they didn't have multiple sources or propagated sources of infection, and I'll show you a propagated example here graphically in just a moment. So this is the incubation meal, and it started. We can see that it started at 7, and so we're going to see what the incubation period is. In this case, we do it a little differently. So we're going to count this one, 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 and we're going to go to the apex. Okay, so if we subtract 4 from the 7, so we got 7, we got 1, 2, 3, 4, 5, 6, 7, 8, 9 hours, right? So the incubation period in this case is 9 hours. Now I want to talk about how long the illness lasts. Okay, well, what we do is we know that the illness reached, or the signs and symptoms for the incubation period reached its peak at about 4 a.m. in the morning. We talk about normally when people get sick, and often it's at night, it's usually not during the day. Well, this is a good representation of that. And you all have had similar experiences yourself. But let me talk to you how long this particular disease lasts. So we're going to go from when it started, when the meal was eaten. So we go 1, 2, 3, 4, 5. Did I start here? I should have. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So the duration, how long was a person sick, was 12 hours. And you saw how we did it. And we could even, if we wanted to, we could calculate the median number of hours, and I think we have, if we do all the counting we'd need to, it'd be 347, and we divide that by 2, and it comes out to 173.5, and so 3 a.m. would be the median if we calculated that way. Now, I want you to just erase that from your thinking, because that's generally an incorrect way of doing this. So, but I just wanted to show you that this is a common source epidemic. You can count it 2 ways. We counted it differently? Not really. We look for the median. We use the apex in the last one. But in this particular case, we found that the 11th case happened in the 4th hour. And so the median was 4 hours. In this particular one, we started with the meal and we looked at the apex, the highest point. All right. So now in our particular case, back here, we've identified it as ice cream. We know who brought the ice cream, or we would do that through an investigative form to see who brought it, and we would use those forms that I showed you from the state and the CDC, and we would ask, how the ice cream was prepared, where the ingredients came from, was there any contamination problems in terms of the counter, and whether it was clean, and whether the person had washed their hands, and whether the container had also been cleaned properly from the last time it was used. We would go through a whole series of things, and we would want to know the grocery store where the products were. We're going to have milk or cream and ice cream and other ingredients, and we want to know where those came from. And then we want to know the holding temperatures. Were they properly held? Were they refrigerated at the proper temperatures so they didn't sit out? But notice with ice cream, it set out a long time at the church supper. So as a result of exposure to air or and whatnot, bacteria most likely would begin to grow. Okay, so there's good reason to understand that and expect that. And remember, when you go to a church supper, you want to look at what you're eating, and you want to look at you sort of want to estimate the risk, and anything that's made with eggs and ice cream or chicken or whatnot is going to be more likely to have bacteria. So if you a coleslaw made with mayonnaise, that would be probably an item, if it's been left out a long time and not covered and not kept at the proper holding temperature, that you would want to avoid. I make a habit, and I don't necessarily recommend this for you, but you can just think about it, is I try and eat before I go to one of these events, because I don't want to depend on those people who have prepared the food and whether they've done it properly and whether the food's at the proper holding temperature. And sometimes it's absolutely not their fault. They bought a contaminated product right from the grocery store. And in that case, we would want to go next to the supplier. Well, who supplied that product? Who supplied those eggs? Where did those eggs come from? Why did they come in the form that they did? And this is where we pull products off the shelf. We make a decision whether a product is contaminated and whether we need to eliminate the opportunity for purchase of that product. Okay? Now, this is a propagated epidemic. I hope you like my line drawing. I know it's not as professional as some of the others, but this should give you some pleasure in just viewing it. You ought to see my artistic talent. I'm real good at stick figures, although they're not very proportional either. But this is proportional, and hopefully this will help you understand what a propagated epidemic is. Now, a propagated epidemic, as it says, extends over multiple incubation periods. So what happens is a disease. Let's take influenza. It starts, and we have some people get sick, and often it looks like it's going to decline, and then it takes off again, and people get sick, and then it looks like it's going to decline, and then it rises again, and finally it plays itself out. And so when we understand what kind of, whether it's common source or a propagated or a progressive epidemic, then that helps us with manpower and expenses and shifts, and how many personnel we're going to need, and it helps us in the planning to cope with a situation like this. And if we would, we've got diseases that we've got influenza that come from different countries, and we're trying to cope with those now by vaccinations. And vaccinations is a whole nother topic, and I would really like to delve into it because it's most diseases have been eradicated by the proper vaccination, but people get lax, or they have other barriers that prevent them getting the vaccination, and oftentimes it's their beliefs. Well, anyway, let me start here. Now, when we talk about baseline, you know this in epidemiological terms. It's okay to call it a baseline, but we would call this the endemic state. This is something that you would take into account, and so we began to go across, and we're looking at this very carefully to see that it begins to build starting here. So this is what we would expect. This is the normal condition of illness, and then we get a case, and that case is, what do we got? We got April 25th, and we're going to go to the 16th here, because that's the apex of this first cycle. So we got 21 days in terms of the incubation period. Okay? Are you seeing how I'm counting this? Now, the next one, we can't be certain what's going on here. It looks like it's going to drop off, but it doesn't. And so we go from the 30th, and it starts up, and we're going to go to the peak. So we're going to go from the 30th to the 4th of July. All right, and if we count that out, we would have 36 days. All right, so we're still dealing with this incubation period. And then it looks like it's going to drop off again. See, this is what we always think. Everybody thinks the tidal wave is past. In reality, it hasn't. So we go to July 13th, and we look at it starts up. It tapers off a little bit, but not enough to be significantly different, and then it continues, and so we go to August 15th. So we look at July 13th to August 15th, so we have 32 days. So in this particular case, our incubation period is anywhere from 21 days to 36 days. So that gives us a minimum maximum value. And okay, we were focusing on the minimum maximum values, and we decided they would be from 21 to 36 days. Now, this information is extremely important to us in identifying the foodborne diseases or the illness, or in this case, we're looking at influenza or pneumonia or any contagious disease. So now when we look at the duration of the disease, this disease runs roughly 5 months. It starts in April, Well, we got April, May, June, July, August, and September. So we got 1, 2, 3, 4, 5 months. So actually, we probably wouldn't count April because we're just not certain that we have a problem. So it would start in May, and it would go May, June, July, August, September. So there's our duration of the illness. How long the illness lasts is really 5 months. Okay? So let's go on with we're in this thought process of a foodborne outbreak and contagious diseases, and we really want to understand more about the investigation of it, because that's what's critical to us, because we want to protect people. That's one of our basic functions. Prevent and protect people is what we want to focus on. Now, this is another foodborne example, and this is a phrase that's become popular, and I want to acquaint you with it. It's from farm to fork, and it gives you the idea that if milk was a problem, or meat was a problem, and we know that 75% of diseases are transmitted by animals to humankind, we would want to go back in the process to from the consumer. You can see that we have at the bottom here that the consumer ingests the pathogens and becomes ill, and then we want to go to the consumer, and then we want to go to the wholesaler and retailer, and then we want to go to the slaughterhouse, and then we want to go to the farm. So you can look at all the things that we might inspect, but we want to go clear back in the process so we know whether or not we've got a major problem that's occurring. So, and this is how we do it, farm to fork. So once you consume it, where in the process did this food become contaminated? And sometimes you'll notice, if you're on the interstate, you'll see a reefer or truck, or trailer, I should say. That's a refrigeration truck, and the doors are open, and they're carrying products that need to be held at a certain temperature, and the refrigeration equipment is broken. It doesn't function properly, and of course, truck drivers are paid by the load, so they're going to try and get that truck back on the road as soon as they can, and they may or may not report that they had trouble with refrigeration because the product wouldn't be any good, and the retailer is not going to want to pay for a product that is contaminated or doesn't meet the specifications that have been promised. So holding temperatures and carrying things down the interstate are an important part of the process too. Now, I just focused on that one element there, but we could go to a slaughterhouse or anything else if we were dealing with meat. We could do the same thing with chickens, so I want you to begin to really think about that. Now, this next term I'm going to introduce to you is a very important one, and it comes from the farm, and a lot of the ideas come from veterinarian medicine, and you understand why, is because of the amount of diseases that are transmitted from animals to man. But herd immunity is an important concept to really understand, because it really talks about a community's response to a disease, and you can apply it in multiple ways to multiple problems. Now, if you allow me, I just want to read to you about herd immunity. It says the resistance of a group of hosts, that's us, where the disease lives, to invasion of an infectious disease based on the immunity of a high proportion of individual group members. So how many get sick depends on the immunity of a population. So if we have high immunity, few people will get sick. And the way to increase immunity could be through a vaccination, but there's multiple other ways, as you know, proper sleep, diet, and you hear these all the time. The problem is that people don't follow them. But for example, people who annually receive a flu shot help control, and this is an important point, help control the spread of influenza in the population. Although many people who do not get vaccinated, they are still protected by herd immunity. Herd immunity makes disease transmission more difficult. So those of you who are getting a flu shot, by virtue of you getting that, and few people get sick from a flu shot, and they ask you whether you're allergic to certain ingredients in the flu shot, and if you are, not to take it, etc. But you're providing immunity not only for yourself, but for others, because you're taken out of the group that potentially could get sick. And so you're not going to be one of those contagious members that passes it on to other people. All right, let's look at this together. Now, this is an example of herd immunity, and we have susceptible people, and you can see right here at the beginning we have an index case and we have co-primaries, etc., as we talked about before. But as an infection goes, these are people who haven't, by the way, probably had an injection for whatever disease we might be dealing with. It could be measles, mumps, or any other disease that's contagious. But they haven't, let's say they haven't had a vaccination. Notice what happens, because so far we don't have many people that have immunity. We have a lot of people who are susceptible. So we have an infection that goes on here, an infection that goes on here, an infection that goes on here, and then it spreads and it spreads again, and then finally we have somebody who is immune to the disease. Now, that immunity could occur by any number of procedures, and we've already talked about that. And then if we follow the strain this way, we find that this person has immunity, and we find that this person has immunity. So, finally we get to this phase of it, the termination of the epidemic, and we find that 17 of these 31 people have immunity, or 54.8% are immune during the termination of the epidemic stage. Okay, so a little over half. Clearly everyone is not immune, and there's still susceptibility. And so you can see how this might be a propagated illness. We got a lot of people ill. We got still people ill, and finally we're going to get down to fewer people who are ill and more people who have immunity than are susceptible. Okay, and that's the point. And if we do our part through vaccination of any sort, we've had diseases that have been eradicated. In other words, they eradicated means that they no longer exist. Well, they no longer exist if people follow the procedures that eradicated them in the first place. I remember, and maybe I shared this with you, I hope I haven't, that in the 60s, polio was a big problem. And so after church, they took everybody to the high school in the small community where I lived, and there was a sugar cube, and they put a little polio on it, and you consumed that, and then you had a little shot of orange juice. And we didn't see polio for a long time. Prior to that, we'd see all kinds of people limping and that were crippled and whatnot. And then polio began to come back because people weren't being vaccinated for polio. And I always get the comment about, oh, the risks really outweigh the benefits. Don't you believe it for a minute? The research data doesn't support that at all. So if you have a chance to get an injection to become vaccinated, you do so. I know many physicians who take a flu shot twice a year because they come in contact with so many people and they can't afford to be sick, and they don't want to be in the process of one of those that spreads the disease. Another policy, I want to just talk about a policy for a minute that is not widely accepted, and I hope you think about it, and I hope you can influence the workforce, is going to work sick. The norm is that that's what people do, is they think they're expected to go to work sick. Well, what they're doing is they're sharing their disease in a friendly fashion, and pretty soon you'll find you've got a situation just like this graphic that's going on, and it could have been avoided. If they would have stayed home and got well, we wouldn't have had a problem in the first place. This going to work sick costs companies all kinds of money, and along with that, a lot of pain and suffering. Okay, so let's look at this. I want to describe this because this has been applied to an HIV epidemic, and this came from a source here at the bottom in 1991, and it put it into perspective. And let me just share with you so you have a good comprehension of what herd immunity is, because that's what we're after. We want an immune herd, or an immune population or group of people. That's our goal. So herd immunity describes the collective immunocompetence of a population and its ability to resist disease. The disease of microbacteria, salmonella, hepatitis A, etc., all these other diseases that are contagious, have been seen in epidemic proportions in the United States, and you can just go through and look at those. Okay? And but probably more correctly, would the word epidemic be correct? Probably not. In the United States, we would say pandemic. Okay, this is just a point, and we're taking this as a quote from these authors, but we would be suspect about using that particular word, and I want you to become astute at recognizing when words may not be used properly. An association between these superimposed secondary infections and the human immunodeficiency virus, HIV, pandemic, can be made since the HIV's imposition on individual immunity has ramifications on a population level or on a population basis through a decline in what? Herd immunity. So conclusions, exploring these pandemic phenomena as consequential to a reduction in herd immunity can provide a unifying hypothesis to explain existing and predict future infectious disease epidemic or pandemic dynamics. The benefits of acting upon these implications has advantages both for HIV infected and the uninfected, as well as all these diseases up here. So if people are really concentrating on protecting themselves, there's all kinds of ways that they can do so that are medically available, proven effective, and should be utilized. Okay. So I hope you have an appreciation for herd immunity, not going to work sick, and vaccinations. And I hope that you will encourage people who are not allergic to vaccinations to take them.